This is Dr. Rockhold welcoming you back again. In this, the third segment on opioid analgesics, we're going to cover three large groups: the mild to moderate agonists, the mixed agonist antagonists, and the narcotic antagonist group. Codeine is considered the prototype of the mild to moderate opioid agonists. It is found naturally in opium, about 0.5% weight by weight. It is a partial agonist at the mu-opioid receptor and is somewhat less efficacious at producing analgesia than is morphine. However, it does produce excellent antitussive effects, and these effects are evident even at doses that are lower than those that elicit analgesic effects. Codeine can be metabolized to morphine by demethylation. And it's very important to recognize that some patients have an avid demethylation phenotype. And in these patients, and particularly in children, enough morphine can be generated from doses of codeine to cause severe respiratory depression. Diphenoxylate and loperamide are used exclusively for antidiarrheal actions. Both are mild to moderate partial agonists. Loperamide is available over the counter. Lomodal, which is diphenoxylate plus atropine, requires a prescription. While these drugs generally do not produce any significant abuse in and of themselves, Imodium has recently been recognized to be used extensively by persons suffering from opioid use disorder. In these cases, what appears to be happening is that the abusers are using very high doses of Imodium to produce a mild stimulation of the mu-opioid receptor, sufficient to reduce or eliminate withdrawal that they may be suffering from another stronger opioid. While we've typically focused only on agents that are agonists at the mu-opioid receptor thus far, with the mixed agonist-antagonist group, we need to consider also actions at the delta and kappa opioid receptors. Typically, the mixed agonist-antagonists act as full or partial agonists at the mu-opioid receptor, but also as either partial agonists or antagonists at the kappa and or delta opioid receptors. Important examples include buprenorphine, a variety of formulations, butorphanol or Stadol, nalbuphine, Nubane, pentazocine, Talwin, or desicine, Dalgan. Developed in the 1960s, the unique properties of these several compounds were believed to be able to provide analgesia with less respiratory depression and abuse liability than morphine or other full mu-opioid receptor agonists. And this is in fact true. These agents have less respiratory depression and less abuse liability than strong agonists. However, misuse or abuse of these drugs does occur and has led to dependence and death. The partial agonist-antagonist actions are such that they may precipitate withdrawal if they're given to a patient who is currently dependent on a full mu-opioid receptor agonist. Similarly, they may block the analgesic effect of the full mu-opioid receptor agonist under such circumstances. We're going to use buprenorphine as the prototype agent of the mixed agonist-antagonist class. At the mu-opioid receptor, it is a partial agonist, but it also has a characteristic of taking a particularly long time to dissociate away from the receptor so that it continues its partial agonist effect for a considerable period of time. It appears to be an antagonist at both the kappa and delta opioid receptors, and it has been noted to be a partial agonist at the nociceptin orphanin FQ receptor. It is currently used extensively for medication-assisted treatment, MAT, for opioid use disorder. When given, it will prevent abrupt opioid withdrawal when substituted for a full opioid mu opioid receptor agonist, but it generally gives less euphoria than does a full agonist. It's important to note that less is not zero, and that buprenorphine has been diverted extensively and used illicitly. The introduction of buprenorphine appropriately in a patient who is dependent on another mu opioid receptor agonist allows the patient to be gradually weaned from the full agonist. There are multiple formulations. There are tablets, there are buccal or sublingual films, and there is now a subdermal implant. And some of these, buprenorphine is combined with the opioid antagonist naloxone in an attempt to provide abuse deterrent formulation. In such combined formulations, you recognize that naloxone is inactive orally because it is degraded very avidly in first-pass hepatic metabolism. So when you give a combination buprenorphine naloxone, there is no antagonistic effect evident from the naloxone, whether it's given orally or sublingually. However, if you take the same preparation and dissolve it for injection intravenously, then the naloxone is not subject to hepatic metabolism in a first pass, and it can exert its full antagonistic effects. Usually in those circumstances, it'll send the chronic abuser into abrupt naloxone precipitated withdrawal. There are two other agents in the mild moderate agonist class with which you need to be familiar. These are tramadol or Ultram and tapentadol, Nucynta. Tramadol is a synthetic compound, mild mu opioid receptor agonist activity, but it also acts as a serotonin norepinephrine reuptake inhibitor in the central nervous system, an SNRI. While it is a mild analgesic in and of itself, tramadol is converted to the liver to O-desmethyltramadol. This is an opioid that has somewhat stronger binding to the mu opioid receptor. Presumably, it contributes to the analgesic effect of tramadol. Tramadol and tapentadol both have analgesic actions and also some tendency towards abuse liability. Tramadol is currently considered to be DEA Schedule 4. In addition to its propensity for abuse, tramadol also contains a warning about possible suicide risk with which you should be familiar. Tapentadol, also synthetic, also mild mu opioid receptor agonist, differs from tramadol in that it only appears to inhibit reuptake of norepinephrine. And tapentadol is DEA Schedule 2. Dextromethorphan is one last agent with which you need to be familiar. It's interesting in that it is a glutamate NMDA receptor antagonist. It has no actions at opioid receptors. It's marketed over the counter as an antitussive. However, the evidence for that antitussive action is minimal. It does not produce analgesia. It's likely that it's a prodrug that must be metabolized to dextrorphan, which is also an NMDA receptor antagonist. It does carry some abuse liability, particularly in very high doses, but despite increased scrutiny by the DEA, it is not currently scheduled. The final group of drugs we'll introduce in this segment are the narcotic or opioid antagonists. These are agents that are highly selective antagonists at all three opioid receptors. They have very high affinity for the receptor, and they're able to compete quite effectively for binding with the agonists at those receptors. And while they block all three opioid receptors, we think their clinical effects stem primarily from antagonism at the mu opioid receptor, as what we have already discussed with agonists having the mu opioid receptor as their primary site of action. These agents are used primarily to treat acute opioid overdose. When given, they will rapidly reverse respiratory and cardiovascular depression and sedation from opioid agonist overdose. This happens usually within 30 seconds to a minute following intramuscular or intranasal administration of the antagonist, a very rapid and life-sparing event. And that's very good and very useful. However, while they are the treatment of choice in an acute opioid overdose, it's important to remember that in individuals who are dependent on an opioid agonist and who are in an overdose situation, given the narcotic antagonist will also precipitate abrupt, full withdrawal in a matter of minutes. This is referred to as naloxone precipitated withdrawal. It's most unpleasant. And as a consequence, usually when the individual regains consciousness, they are typically highly agitated. We'll talk about dependence and withdrawal in greater detail in later lectures in this topic block. They have very few other physiological effects that are noted, except for very occasional short-lived elevations in blood pressure. Very safe agents. They serve an absolutely indispensable need in managing acute opioid overdose. Naloxone, or Narcan, is the prototypic and most commonly used opioid antagonist. It's only available for parenteral or intranasal administration, as it suffers from extensive first-pass degradation following oral ingestion. It's relatively short-lived, 30 to 60 minutes in duration usually. And remember that it is a competitive antagonist, so it may be necessary to administer multiple sequential doses to overcome large doses of opioid agonist and to maintain antagonism if that agonist has a longer duration of action than the narcotic antagonist. Nalmefene, or Rev-X, is similar to naloxone. It must be given parenterally. However, and it does not have an intranasal formulation as yet. It has a much longer antagonist action, however, than does naloxone. Naltrexone, Revia, or Dipade, is the only orally effective opioid antagonist. It has a prolonged duration of action, up to 48 hours, and there is an extended release formulation that is injectable, Vivitrol, and Vivitrol has been used in medication-assisted treatment, MAT, for opioid use disorder. Acute opioid intoxication is a medical emergency. It commonly presents as a triad: depressed consciousness or coma, meiosis, and severely depressed respiration. Naloxone, Narcan, is now available from pharmacies without a prescription. It can be used widely by persons with an opioid use disorder by their friends or families, and it is commonly distributed to first responders in many of the states. All of these have been found to be effective in reducing opioid deaths. It's available both as a pre-filled syringe, as an auto-injector, and as an intranasal spray. While the actions of the opioid analgesics to cause constipation may not seem like the most dramatic effect that they can produce, this nevertheless greatly complicates management of pain with these agents. We now have 3 opioid antagonists that are available to you for use in restoring bowel function in patients who suffer from opioid-induced constipation. They are alvimapan, Entereg, methyl naltrexone bromide, Relistor, naloxegol, or Movantik. These agents are effective because they are narcotic antagonists and they are not able to gain entry into the central nervous system. Thus, they do not antagonize the analgesic, the antitussive, or other CNS actions of the opioid agonists. They act exclusively on mu-opioid receptors on intrinsic neurons within the gut wall and allow an increase in bowel motility and tone to be restored even while opioid agonists are able to continue combating pain in these patients. These have proven to be very helpful in many circumstances. Let me finish up with these take-home points. Opioids are unexcelled at acute pain management, but we need to recognize that there are significant differences among and between the agents that are available. While they have great utility in pain management, increasingly concerns about tolerance, dependence, and abuse are taking precedence in how we look at and use these drugs. And we'll talk more about these in later lectures. And then finally, recognize that we do have true antidotes to the actions of the opioid analgesics, and these can be life-saving in crisis situations. I want to thank you for your attention. I'll talk at you in later lectures. Goodbye.